So hello everyone, sorry about the technical difficulties. We've got a new link out now. I've got some emails here. Just going to give people a few minutes to log on to it. But what we're going to do is a review of sports medicine emergencies. We're going to take a look at emergency action plans, managing airway, breathing, and circulation emergencies, as well as taking a look at heat-related emergencies, keeping in mind different venue considerations along the way. So let's get started. So our objectives today, want to be able to understand the planning behind emergencies. That is really the most important part for responses to go well, and that includes taking a look at personnel, different communication equipments, and lines of communication, as well as different emergency equipment. Want to be able to understand what your role is going to be in terms of a multiple casualty. It's slightly different from taking an individual emergency one on. And thirdly, we're going to talk about how we can essentially approach the managing difficult airway from an on-field perspective, and finally recognizing and beginning to treat heat-related injuries. So the emergency action plan, whenever you're covering a sports medicine event, sporting event, whether that be in a hockey arena, a football pitch, or perhaps out on a trail, there's a number of things you want to consider. The basics in terms of approaching that are coming up with something called an emergency action plan. And what that is essentially is having a discussion with your partners for the event, and how you want to both communicate to emergency services, but also with local hospitals in the event of an emergency. And so from a phone numbers perspective, it's very important to have those on hand ahead of time. So you want, obviously, from an EMS perspective, but also the site manager. That's important if you're talking about a venue and you've got a number of different access points that need to be managed. Security, perhaps, if we're talking about a venue where there's a large audience present, you may need them on board with helping to manage the security. And like we talked about, the nearest hospital, but also in terms of other additional medical staff, whether that's your first responders, which may be your athletic therapists, your physiotherapists, and other first responders that are present at the event. Directions are a very important thing to consider, and sometimes they're often forgotten with respect to emergency action plans. And sometimes it can be quite difficult for EMS, even in the advent of GPS systems, to find out not just the location where you're at, which may very well come up on the GPS, but how to access specifically your emergency. And so thinking that through ahead of time, whether you're essentially on a running trail, and thinking about how EMS might access a runner that's down at certain points along the trail, and what the quickest route out. Thinking about that ahead of time can make things run a lot smoother. And then finally, equipment will go into where you should keep equipment based on certain venues, as well as what is kind of the necessary equipment for covering a sports event. So when we think about venues, there's such a wide variety of sporting venues available that present a number of different issues. If you're thinking about, for example, covering a skating or ice hockey event, you've got essentially a cold, hard, slippery surface, which not only poses an issue from a temperature perspective of the injured athlete, but also a safety concern for the medical staff approaching the athlete. And when you think about other venues, I've put just a few options here. They all present very unique situations which have to be thought out ahead of time and which in fact may require specialized medical staff or allied medical staff. So for example, equestrian events, you have not just athletes, but you also have animals as well. And you'll often have to coordinate your services with veterinary services to essentially ensure the safety of the athlete in relation to the animal as well as the animal. Trampoline is another interesting one. So I'm going to pose a question to our audience present here. Alex, if you were to have a Olympic trampoline athlete suffer a cervical spine injury, and they are currently lying motionless on the middle of the trampoline, how would you approach that athlete to essentially secure the C-spine and further assess? For those of you who can't see, Alex is currently sweating profusely while thinking about an event that he's never actually covered.
I mean, this is definitely something that you would want to prepare for before the event were to actually occur, and try to at least go through a mock trial beforehand to ensure that you are prepared for the situation.
Is there a concern about the surface?
Yes. And honestly, maintaining stability of the spine it would be challenging in this perspective.
What's the issue with approaching the athlete on the trampoline?
Causing more motion and further injuring their cervical spine injury if there is one.
So for somebody who hasn't, such as Alex, can you think of a way you might essentially approach that situation then?
I think trying to get people to maybe provide some counterforce to the actual trampoline to minimize motion.
So there's a couple of different described techniques. One is to essentially take planks and essentially support underneath the athlete, and also provide essentially a plank walk, so to speak, so that the medical staff can then approach on the trampoline but over top of the plank so that the athlete's not moving. In lesser resources, people have also described essentially having essentially additional medical staff going underneath the trampoline surface and essentially using their backs to essentially hold the athlete up so that they're not under tension. And then I showed another one on the right there, which is the 2015 already? The Pan Am Games? Is it that far along?
2015.
2015. Wow.
Yeah, in Toronto.
That was the diving pool from the 2015 Pan Am Games in Ontario, and not just from a diving perspective, but obviously the swimming pool adds an additional essentially complexity to responding to emergencies. So, wanting to have lifeguarding staff for extradition from the water. Similarly, from a water sports perspective, so covering like water skiing, water jumping. Those are also considerations that you take. So that's just talking about very specific features of those venues. There's a number of different other issues that will come up depending on the way the building is structured. And from that perspective, you always want to consider access. So whether you're talking about that swimming pool or you're talking about the equestrian grounds, or the trampoline for that matter, knowing which entrance is most easily accessible by EMS and being able to essentially both write out the directions and think out the directions ahead of time so that you can foresee any kind of issues and obstructions ahead of time. And that may require, like I said, coordination where you are communicating to a building supervisor or manager and security staff to coordinate moving of certain equipment in the event of an emergency. Communication is key, and having an emergency action plan printed out and placed around your venue is very, very important so that essentially all members of staff are on board with what the plan is, who to communicate, what the phone numbers are, and how to coordinate access through different gates and doors. And from a personnel perspective, we've talked about that a lot already. But they should all be available through the numbers or radio channels provided on the emergency action plan.
Yeah, that's interesting because I think the other thing that you might mention is sometimes, especially for larger events, the venue changes once the media arrives, and then all of a sudden the access points that you previously walked through suddenly change, as especially if it's a higher profile event, and then that access point is just covered with media that just occupy whatever open space is there. So
Exactly, and that's what I was saying. With the larger events, that's where you're going to have security coordinated in, um, and play a huge role in terms of clearing out. I was talking about equipment there, but obviously people as well, so that you can get that access. And there's obviously we're approaching it from the sports emergency perspective. There's obviously other venue emergencies that can occur, such as in terms of acts of terrorism, attendees carrying weapons, so a sighting of a gun, for example. And then there's essentially natural disasters, fires, and a number of other things that have to be considered as well, where you may be involved in terms of essentially caring for the athletes in terms of evacuation. So, yeah, there's numerous considerations, and so it's actually it's okay to have a bit of an imagination when coming up with the emergency action plan. So at this point, what we're going to talk about is the equipment. We're going to move on to the equipment. So most people have cell phones available, but as we've seen over the years, a number of these well-constructed sporting venues have poor reception, and often radio is the way to go still. So I think sometimes it's helpful to have a backup in some of the building structures to make sure things go smoothly. And what I've done for table one, if you take a look, is essentially review the equipment that we recommend for essentially covering a sports event. And I've broken it down based on essentially the different emergencies based on airway, breathing, circulation, disability, and then other. And I think if you have most of these, you can essentially take care of most athletes until emergency medical service or paramedics have arrived for transfer to a tertiary care center. So from an airway perspective, just have a number of airway options as adjuncts to some of the manual methods that we'll be talking about shortly. So oral, nasal, and laryngeal, oral and nasopharyngeal airways and laryngeal mask airways are considerations. If you only have one or two of those, that's fine. I think it's important to have something else in your bag of tricks in case you come across an airway emergency. From a breathing perspective, obviously it's ideal if you have oxygen on board, but I think at the very least you should have a bag valve mask. They're not very expensive. You can get them on Amazon now for about $20, $25. An O2 SATS monitor is not necessary, but if you have it, once again, that's another great tool giving you some extra information on the condition of the athlete. From a circulation perspective, especially with the larger sports and with the increasing watch now for cardiac emergencies, I think it's important to have an AED for larger events, even if it's being used on crowd members. It's still something that's very helpful to have. And for the rarity of what a cardiac emergency is, having an AED present when one happens I think is something that's important to have, especially from a physician perspective. The other one I talk about is having a blood pressure cuff. Obviously gives you more vital information and allows you to essentially monitor the patient. The same thing with the O2 SATS monitor. Blankets from keeping them warm perspective. These are some of the more conservative management and reassuring things for athletes when you're awaiting transfer of care. Obviously, from a disability perspective, considering about a C-spine collar, and depending on what event you're covering, you may only consider having a spine board, although those will often be essentially used once EMS has arrived. And some of the guidelines around that is changing. But I think it's important. One of the pitfalls we see both in ATLS teaching, but also from a sports medicine perspective, is once a C-spine collar is applied, that does not indicate full immobilization of C-spine. You still need to maintain stabilization either by blocking in the patient's head, by attaching it to the spine board with blocks on either side, or maintaining it manually. And then obviously some personal protective equipment and the other, as well as some adjunct breathing and airway medications, epinephrine and Ventolin, some splints, some bandages, and finally having a lighter torch to assess within the oral cavity, specifically obviously taking a look at dental injuries and oral lacerations. That's very helpful in looking in the eyes as well.
I was just going to add for airway, I guess one of the, in the chasm, emergency equipment list, I believe some had mentioned like having McGill forceps. Speaking of looking in the oral cavity to look for.
Yeah, so so some of the more advanced things you can get. So McGill forceps for moving a foreign body. I think especially if you're in a cafeteria environment. But all jokes aside, I think that's a reasonable adjunct. I was trying to limit it to kind of the bare bones, but you can also get these very small, handy cricothyroidotomy tools, which essentially you can have easily in like a fanny pack, where you essentially unscrew, you can alcohol swab or hexidine the end, and essentially it has a sharp point. Locate the cricothyroid membrane underneath the thyroid cartilage, and essentially go in. Now, these are, I would say, they are obviously life-saving maneuvers, but to be perfectly honest with you, the chance of that happening is quite rare. But also, if you're not at all comfortable with doing that procedure, I don't think that should fall within your realm of essentially attempting. But yes, there's a number of different other things that you could definitely add to that list.
I think the spine board is also useful as an adjunct for transporting athletes. Like not necessarily even if you're concerned for a spinal cord injury, but if they're on the ground, unable to walk, if they have the lower extremity injury.
On the ice as well.
It's good, a great adjunct to it. But making sure you get them off of that as soon as
in the water as well, actually.
Yeah.
So you could in the water, essentially, you can bring the swimming athlete or the diving athlete over to the water. Have them essentially the lifeguards essentially load them onto the spine board in the water. They can be strapped in the water, and then once they're out in one piece. So you can do full C-spinal mobilization from that perspective. That's a great point, Alex.
How we lifted him, and then once he was on the stretcher, we took him off the spine board because he wasn't getting much of that.
So in summary, from the emergency action plan, this is something whereby if you're in any way concerned, you should be activating the emergency action plan, calling EMS early, and getting security or building manager or site manager involved, as well as your other medical staff. You can always call off the emergency action plan if everything turns out to be fine. But what you don't want to do is waiting to the very last minute, because that's delaying treatment for the athlete. In terms of using an ABCD approach, which we're going to talk about shortly, assessing both the airway, breathing, circulation, and then disability, it's very helpful in terms of not missing anything, but also not essentially skipping essential treatments along the way. And then keeping in mind the different emergency equipment and personnel required for an emergency action plan. I have this labeled as case number 2, but obviously this is first case. So what we've got here, you are essentially working at a training facility for a soccer club, and you were inside of the dome, and you went inside to get some equipment, and you hear a loud crash and bang, and as you come back out to where the dome is, this is what you see is essentially a large collapsed structure. So the idea of a case here is I want you to think about, first off, what you're going to do in terms of, one, how you're going to access that area. You have at least 20 athletes and 3 coaches in there, as well as an athletic trainer. what kind of things are you going to want in terms of trying to assess the situation, and what kind of personnel are you going to need, and who else are you going to need to call. So I want you to try and think through, Alex, in this situation. First of all, what are you going to do? Are you going to run right in there? Or are you going to...
No, I mean, first of all, and this is something you want to make sure it's safe to enter. It's a dome, so whether there's any electrical things that could pose further risk to yourself or to people that are in there, most likely you're gonna start activating your emergency action plan at this point. And again, checking the perimeter to make sure that's safe to enter, and seeing if there is actually even an entry point that you can make it through. If you do deem that to be appropriate and it is safe enter, I mean, for doing that, you want to see if there's other people around that you can potentially are either skilled, whether that's therapists or front desk staff or anybody else that could help you. And then kind of once you're in there, you want to survey the situation, and if this is more of a hopefully not like a mass casualty situation, you want to see if there's people that are either deceased that you're not going to maybe attend to them right away, or people that are in obvious distress that require immediate medical attention, life-saving medical attention, that you're going to go to first, compared to somebody who is yelling and screaming, that maybe has a cut or a broken bone or something that, although their injury is important, it's not life-threatening at that point. So that would be kind of an initial triage assessment.
I think that's a great synopsis of some of the considerations that you need to take into account. Your role really changes in these mass casualty situations, and the kind of important parts are assigning clear roles to those people that are available, and communication is key, because really you've switched from essentially a treating and managing an individual to more of an information gathering and delegating limited resources to a very few number of people. And once again, the goal here is a greater good for the greater number of people. And the triage that we talk about is similar to what Alex was mentioning there. If somebody is in immediate need of essentially attention, where they're going to deteriorate quickly if they don't have it, that's the top priority. Somebody who is essentially, unfortunately, if they've died as a result of the casualty or trauma, or somebody who is essentially expected to die, so with severe injuries, perhaps like a severe head injury with other limb injuries, that you're aware that with your current resources and current time are not going to be able to help. Unfortunately, those people do go to the bottom of the triage scenario, beyond the essentially late or minimal treatment required people. And that's how, in terms of from an ATLS perspective, that's what they talk about in terms of immediate or these immediately life-threatening injuries. So we're talking somebody who's alive and may have essentially an airway issue, or breathing very fast, or perhaps essentially at risk of losing a limb. The more delayed injuries, then we're talking about things like dislocations, fractures, as opposed to kind of the more minimal injuries, which we might have a sprain, or some of the anxiety attacks that go around essentially seeing as a traumatic event. And those would go to the top of the list. So from a summary of the way to deal with an emergency, an emergency situation where you have a mass casualty, we really want the sports medicine physicians taking a leadership role, and trying to gain as much information. And that may mean you call EMS before entering the site, calling the site manager, calling other medical over, and then upon entering, assessing who's down out of the 20 athletes and the 3 coaches and the athletic therapist, and then calling EMS back to let them know what the update is. That's one of the things in terms of maximizing communication that's very important in the situation. So we're going to move on to airway and breathing. This diagram I find very effective for illustrating the point. Airway issues are one of the more scary emergencies, not just in the emergency department, but also in real life. So I always find it that it's helpful when we're talking about these things to try and simplify it as best as possible, so that you can easily think through this in an emergency. As you can see, there are two patent access points for the airway, one through the oral cavity and one through the nasal passage. In the absence of a C-spine injury, obviously you can do a chin tilt to make that straighter and you can give greater access of oxygen to the lungs. But the other thing that it illustrates is essentially how obstructive the tongue can be in terms of the airway. So when you take a look at the picture there, you can see that even in where the tongue is essentially not being retracted or anything, it takes up the majority of that oral cavity, and that's really the important of the jaw thrust as in terms of a manual treatment that you can do for the airway, which is extremely effective and safe to do with a C-spine injury. So what we want to take a look at here is understanding that airway anatomy so that we can maximize our treatment in terms of airway emergencies, describe no equipment and equipment techniques, and then to understand both airway and breathing adjuncts. Okay, so this is actually case number 2, properly labeled this time. So this time what we have is we have a soccer goalie who is essentially was noted to be increasingly short of breath and then essentially passed out and collapsed on the pitch. And he's got very, very shallow stridorous breathing at the moment, and the athletic trainer has gone out and has called you over, as well as EMS. Mark, what are you going to do in this situation? How are you going to assess the situation? You've got it out there, you've brought your medical bag, got all the equipment you need. What are you going to do in this situation?
And it's a stoppage of play, obviously.
Yeah.
So nobody else is going. This is soccer, you said?
Yeah.
Okay.
You're now out in the pitch, you're right next to him, and this is what you hear.
So I guess with Strider, the immediate concern is an airway obstruction. So I guess first thing is to actually do the. Did we witness actually how he felt?
So what you witnessed essentially is he was shown to be demonstrated essentially first tripoding, where he essentially put both his hands on his knees, increased breathing rate, and then eventually just collapsed to the floor.
Oh, okay.
Collapsed to the field.
So instantly you'd activate EMS, or activate your emergency action plan, which ultimately we'll call EMS. And then you, if you're the charge person, you have to try and open the airway and see if that changes anything.
Great, so how are you going to try opening the airway?
So I guess so jaw thrust in this case.
Excellent. So you do a jaw thrust and slightly diminishes the stridor sound that you hear.
Okay. Next thing would be to, if you have access to your tools, then try and insert one of the airways that you have.
Excellent. Which one do you want to give?
Opening. So let's see, I guess. If you have, do you have a nasal pharyngeal?
Yep. So you put in a nasal pharyngeal airway. It's quite a bit of resistance as you're putting it in.
Let's see. And then, okay, quite a bit of resistance.
Mm-hmm.
Yeah, I guess then you have to go lower in that case.
Okay.
So I guess if you look in the oral cavity.
Great.
Same, yeah.
So you take a look in the oral cavity. There's a mouth guard.
Remove that.
Okay, you remove the mouth guard. Okay, and you take a look in, and the tongue is very, 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 very swollen. Looks like he has about 4 or 5 tongues worth of one tongue.
So you're not going to get past that, in other words. Okay. And then still stridorous.
Still stridorous.
So then I guess the next one would be to, do you have a cricothyrotomy kit?
So there is one. It's in the back of the stadium. Somebody's wanting to get you one. What do you want to do in the interim?
Bag valve mask.
Excellent. So you do bag valve mask. There's quite a bit of resistance, but you're able to get some air in. And you can see chest rise both sides. What else can you add to the bag valve mask?
I guess oxygen.
Oxygen, excellent. Even better. Alex wants to put on the O2 sat monitor. We've got an O2 sat of 88% with the bag valve mask and some O2 going. What else can you add?
Do you have the ability to intubate?
You don't? No. Now you bring up a great point. So if you're thinking cricothyroidotomy, it's definitely an option. So if you had that, that's something you would consider. But there's something else you might want to kind of consider in this situation.
I think like with the swollen tongue and kind of flaccid, probably up and yeah.
I think it's a consideration. And this is something whereby we don't always have the history, but you can have essentially somebody playing rugby and get stung by a bee, or somebody with known severe anaphylaxis to different foods, eat something either at halftime or before the match for energy, and essentially then develop anaphylaxis while they're on the pitch. So I think it's an important exercise to go through in terms of to try and think through those processes. And thank you, Mark, for going through there. And that's what we're talking about in terms of the no equipment methods. So if you're out there and you don't have any of those things, what can you do? So if we're not concerned about essentially a C-spine, you can do not just a jaw thrust, but you can also do a chin tilt as well. Clearing the airway, so making sure to remove any equipment, so the mouth guard that you found, for example, doing a finger sweep if there's any kind of food present, or perhaps the teeth or other kind of obstruction. So maybe another piece of equipment that was taken in, whether we're talking about a tackle in football. Obviously the jaw thrust, and then the ventilation. So you have increased resistance. Okay, that doesn't mean you can't necessarily get anything by. It just means you may need to give increased pressure. So with ventilations or with a bag valve mask to get move air past. When we talk about equipment that you can use, I use the mnemonic SOB for short of breath, and then epi. So suction for any kind of aspiration. So that's the kind of the bloody mouth situation, or if they're gargling, you're hearing a gargling breathing sound. That's very helpful. Obviously, oxygen. Getting them as much oxygenation as possible, especially if you're seeing those sats low. Even if they're not moving that much air, some of that O2 will go in, so that's an important adjunct. And then the bag valve mask for increasing the pressure. Epinephrine for anaphylaxis, and then from a breathing adjunct, Ventolin for your asthma. And you asked about the intubation. Really and truly, I'm yet to come across essentially apart from essentially motor vehicle sporting event where essentially airway has become definitive airway management has become a standard. There's an argument whether or not that is particularly safe in the field, and also whether or not that's best done by advanced care paramedics. So yeah. So from an upper,
In our kits are typically non-rebreather masks, or they're just like nasal prongs in terms of oxygen. I haven't looked specifically into our chasm bags, but I would imagine probably a non-rebreather would be better.
I don't have a chasm bag. I just have my own. So what do you? What
No,
does
I'm
it
saying
look like?
you would rather have a non-rebreather than nasal prongs to attach to oxygen. You're able to deliver 15 liters of.
Yeah, I mean, if you're going to have to give oxygen, I think that's probably reasonable to have the mask as opposed to the nasal prongs. I mean, you can still turn up the nasal prongs way up, right? But yeah.
Yeah, I think that would depend on resources available.
We talked already about nasal and oropharyngeal airways, and then obviously contraindications for managing the airway. So complex facial fractures, jaw fracture may allow you to do a nasal pharyngeal airway, but essentially prevent you from doing perhaps an oral pharyngeal airway. And so the troubleshooting the airway from start to finish, you want to obviously clear the airway. So if there's any kind of helmet on, you want to remove the helmet or face mask, finger sweep, remove any kind of mouth guard or other equipment. Make sure you're not missing anything like a dental injury such as a tooth. Positioning. So positioning is key once again. So getting if the C-spine's immobilized, doing the jaw thrust, otherwise getting a chin tilt to maximize your airway space. Ventilation, obviously giving breaths, considering using a bag valve mask. And if no breaths go in, then consider essentially what Mark was talking about, using either an OPA or NPA and bag valve mask. And then if that still fails, you can always consider doing chest compressions. And those people, if your airway in an airway situation, they will arrest. So you may end up doing those anyways as a result. So case number 3, we're talking about respiratory emergency. So you have an athlete, once again we're covering a soccer match, athlete increasing short of breath, and essentially he is stopped running and is in a tripod position. You go out and you hear quite a bit of wheezing. So what are you going to do, Alex? I can assess the situation.
So first of all, obviously you want to make sure there's a stoppage in play before you enter the pitch. Approach the athlete. Quick way is just asking to speak to you, asking what his name is, what happened, see if he's able to speak in complete sentences or not, to assess whether his airway's patent. If he's having...
And he wheezes asthma to you.
He wheezes asthma to me, okay. And I would obviously bring out my bag with me and my supplies. I think given that he's had some wheezing, I think giving him some Ventolin would probably be a good starting point. Let's start there. We'll also assess it to ensure that this is an anaphylaxis. If there's any other signs of swelling of the oral pharynx, of the lips, of the tongue. And
Do you want anybody else there?
yeah, I mean, if I have therapists with me, I think it'd be essential. If he's able to come off the pitch, it may be better to manage him off the field of play, just in case he were to deteriorate. If it's safe to do so, if he's able to walk on his own power.
So let me ask that again. Would you want somebody else there? Let's say you have the ability to measure his O2 sats. Would you want anybody else there if his O2 sats were 97%?
No.
Okay. 88%. Who would you want? Is there anything else you want to do? Yeah. Yeah. And this is the other interesting thing is sometimes you'll be responding and initially you don't need to activate the emergency action plan.
Yeah.
But as a case develops or a situation develops, you may need to activate it as the situation worsens. And I think this is a kind of setting whereby with the mild asthma, it's completely reasonable to treat without activating an emergency action plan. However, if that situation were worse or not to improve with the Ventolin treatments, I would be very quick to activate that. Okay. So obviously asthma, lower airway, atopy disease cause restriction and outflow of air from the lungs. Typically responds well to inhaled medications, but sometimes not always, and may need some further treatment. You can always give back-to-back salbutamol inhalations with the inhaler present.
Use a spacer.
Yeah, use a spacer, and I put down Q5 minutes. You can give it back quicker than that if necessary. Some studies showed as effective as nebulizers. So, okay, case number 4. So you're covering a same soccer match, and another athlete goes up for a header, gets essentially a huge elbow to the right side of the rib cage, and is now essentially coming over to the sideline, acutely short of breath.
So he's on the sideline right now?
Yep.
Okay. So I think initially I would lie him down. Just have vital signs if I'm able to. Start off with our airway. See what his vital signs are. If his vital signs are stable, we may not need to activate the AP just yet. Seeing if he's speaking again, seeing if his airways is patent or not.
Airways patent?
So then moving down to B would be breathing. So I, take a look at his chest rise in terms of inspection, see if there's equal or symmetric chest rise, look at the trachea to see if it's deviated one way or the other, and then take my stethoscope and listen to his lungs to see if I hear any sort of diminished breath sounds to either side.
So you get diminished breath sounds on the right side,
The right side.
almost absent.
Yeah. And is there set of vital signs?
What do you want?
O2 sat, blood pressure,
O2 sat's 92%.
92%. Okay. And is he in distress with like a extended neck veins?
So, no distended neck veins. His respiratory rate's about 25.
Okay.
And he's got increased work of breathing, but he
Yeah.
can talk to you.
Right. So I think at this point I'd activate my emergency action plan and get EMS over. Be concerned for tension pneumothorax, or right now probably just a regular pneumothorax. If his vital signs are relatively stable, but depending how far out EMS is, and depending what your resources are, obviously you want to apply oxygen to him via non-rebreather, nasal prongs, what have you. But definitive management would be a chest tube and want to get a chest X-ray, or you could do a needle decompression or something like that. If it's an emergency.
You asked some things. If you're concerned about once again, this is not something that we're going to be managing on field.
Right.
From a definitive perspective, putting
Right.
a chest tube in, but in terms of that's irregardless of the fact that we can still manage the basic symptoms until EMS transfer. So recognizing once again as you're assessing that things are not going as well as would hope. So getting some information like an O2 sat, noticing that the breath sounds are decreased. Activating that emergency action plan allows that player to get the definitive treatment that they need. Okay, regardless of whether you don't know what type of pneumothorax it is. There are ways of taking a look clinically, but that's important. So I think that's an important thing to keep in mind there. Okay, so in summary, from an airway and breathing perspective, you want to use all your no equipment techniques, especially from a first response perspective, using your adjuncts, so the suction, the oxygen, the bag valve mask, the epinephrine consideration, whether you need Ventolin as well, the upper airway aids, and then activating that emergency action plan early. Okay, or if as the situation evolves and you see that it's getting worse, always remembering that you may need to activate that. Circulation. So, case number 5. Once again, we're covering another soccer match, and it's the second half, and about 15 minutes in, ball's gone into the opposite half, and you look back, and one of the defenders is essentially just kind of stumbling and then collapses. So what are we going to do in this situation, Mark? Athletic therapist runs out and immediately calls you over. Okay, and you're running out with your emergency bag.
Stoppage of play.
Play still going on, actually.
Okay. So then, I guess first step is, activate emergency action plan, and in that, I guess, request for stoppage of play, so that's safe for you to go out.
Absolutely, you've got to communicate to the officials. Okay.
And then, I guess when it's safe to go out, then go out as soon as possible with your equipment. Check the airway. I guess, is there any breathing going on at that point?
So at this point, there's no movement there.
Okay.
No breathing.
So then, so no obvious C-spine. So chin thrust, or chin tilt. Give a couple of breaths. This is a chest rise.
Chest rises.
Okay. Is there any pulse?
There's no pulse.
So then, apply the I guess you have an AED with you.
Got the AED with you? Yep.
So apply the pads.
Yep.
Start the AED.
Okay.
And then
AED's warming up.
And then start chest compressions.
Okay, so you start the chest compressions.
A couple of breaths, chest
Perfect. You're doing 30 to 2. And the AED is now turned on. The batteries are out. You've got the batteries back in. Okay. And you get to the end of the first cycle of chest compressions. Check for a pulse. You don't believe you feel anything. And the AED recommends a shock.
And ask everybody to, I guess, as the AED probably is going to tell you, so listen to the AED and then clear out. Everybody clear. So it delivers the shock and then restart right away.
Okay.
And then I guess it'll
restart the chest compressions.
I'm sorry. Yeah.
Alex comes out and he says, "What else can I do for you?"
Okay. So you and the therapist are there.
You.
So me and the therapist
and Alex are now there.
And then Alex is now there. So okay, I guess at that point. So I guess since I'm already,
You're busy doing chest compressions.
So then he could do the secondary survey.
Okay. What else do we need to do? Yeah. So keep communicating back, right? Keep communicating back. You mentioned at the beginning in terms of activating an emergency action plan, that's essentially. But the main thing here is with a sudden collapse, recognizing and once recognized that there's a pulse, is the quality of chest compressions is the key, and applying the AED that you have, that going to give the best chance of survival.
And chest compressions while it's charging.
Absolutely.
As well.
Yeah. Yes. And chest compressions after delivering the first shot. Yeah. So understanding the symptoms that can be associated with arrhythmias is an important feature of this part of the assessment, and describing, our first response approach to cardiovascular emergencies and describing these actions prior to the arrival of paramedics. So it's kind of a changing phenomenon. What we recognize as cardiac symptoms, obviously the obvious ones are chest pain, shortness of breath, palpitations, and even dizziness. But in fact, they may not have any symptoms, and that's kind of the scary thing. In terms of the other things that can happen, so in terms of how they present, so they may have essentially sudden, profound fatigue. They may just collapse, or they may present as completely disoriented suddenly. And in terms of arrhythmias, these can lead to essentially reduced brain perfusion, which can give an individual symptoms of feeling profoundly sick to their stomach, vomiting, dizziness, changes in vision, syncope, so passing out, and confusion. So it makes it all that more difficult in terms of your assessment, but that's why I want you kind of to consider a cardiac cause to that kind of acutely confused or disoriented athlete. And obviously always to consider when we have a sudden collapse episode. So when we have a player with a pulse, such as like a rapid pulse, you can always request an AED, and the reason being is if the athlete were to deteriorate. You have that ready until EMS transfers. It's kind of like that step whereby if somebody were going to a VTAC or VFib from their arrhythmia, that you're kind of already prepared for that scenario ahead of time. You saw in terms of when we were playing out that scenario, the time it takes in terms of even when we're just sitting talking about the scenario to go from essentially arriving at the athlete, recognizing that they're not having a pulse, and then applying the AED. You can only imagine in real life that even takes more time. So in a situation where you may have essentially a stable athlete with a rapid pulse, you can consider having that on. You don't necessarily have to have the AED on, but put the pads on, and then you can turn it on afterwards if necessary. And then considering Valsalva maneuvers as essentially a non-equipment or non-medication treatment. Anything else you can consider in terms of a treatment from a rapid pulse perspective?
Can you do ice water block?
You can do ice water block, which is kind of like a vasovagal. There's the poor man's way of giving essentially like a quarter liter or 250 milliliter bolus by just doing a leg lift, passive leg lift. It's obviously temporary, but sometimes that can give effect with helping manage. In terms of the different tachyarrhythmias, obviously there's sinus tachycardia, which we'll see fairly often just because the athletes have been moving around. But a ventricular tachycardia, that can go anywhere from 120 150. That can be shockable. They may be stable in a ventricular tachycardia, so they're not necessarily unconscious or unresponsive. Supraventricular tachycardia, they can go quite quick, and they can go upwards well over 200. Then the other one is in terms of ventricular fibrillation, and those are the kind of getting into the pulseless patients and sudden collapse. And once again, that's also shockable and should be accompanied with some CPR and AED. And that's what we're talking about then when we talk about the player without a pulse, activating that emergency action plan as we talked about. Making sure that you get full recoil is a very important piece to the chest compression. So you're going down to about 2 inches or 5 centimeters with chest compression, and it's very important that you let your hands fully recoil back up. Okay, that allows essentially not just for the lungs to open up to move in air, but more importantly, it allows essentially the ventricles to relieve pressure so that they can fill again, so that you can get ready for the next compression. And you're looking at a rate of about 100 per minute. Okay. And the other thing to consider in the sudden collapse, obviously, is the blood glucose. We talked about some other adjuncts equipment. That's another one from a glucometer perspective that might be worthwhile having on hand. So number 4, we're going to talk about essentially disability, so neurological and C-spine injuries, and how to approach those from a first responder perspective. So covering this never-ending soccer match of
So everybody's falling all over the place.
emergencies, and you've just sent out your cardiac arrest to the hospital. EMS has come back, and you're just sat down to drink your tea, and the goalie has gone head first into one of the defenders, and then essentially speared himself into the ground and is lying essentially motionless. So what are we going in that situation? The play has stopped. The athletic therapist has gone out and has done a great job in terms of starting the immobilization of the C-spine, and as doing so is yelling your name.
Right. So I mean, at this point, play stopped. I would activate EAP again because this appears to be a pretty serious situation. I think the first thing I would do as well is recognize what position the patient is in, if they're lying prone or if they're supine.
So they're I mean, in this situation, they're lying supine. So.
Okay.
Yeah.
So, obviously making sure that when you approach the patient, start at your ABCs with your equipment bag, see if the patient is conscious or not, if their airway is open or patent.
So the airway's open.
Airway's open.
They're breathing.
They're breathing. Okay. And then I would go to C next, and
Pulse is present.
Pulse is present. So now moving down to D and completing the classical coma scale.
You get a blood pressure as well. Blood pressure there.
Yeah.
It's fine. It's 120 over 8.
And heart rate.
Heart rate is 80.
Okay. So I'm not concerned with like a neurogenic shock or anything like that at this point. So moving on to D. Is the patient awake? So
Patient not awake.
So assessing whether their pupils are, if they're opening their eyes to pain or voice more spontaneously or not at all.
So they're kind of slowly opening them to the pain.
Okay.
And he's also bringing his hands up when you essentially do a sternal rub.
Sternal rub. Okay. And like speaking. So again, going like speaking and motor. To get a glossophoneal scale.
Kind of mumbles when you do a sternal rub.
Okay. So sound, so you're like 4 right now, and then see if they're withdrawing or vocalizing.
And they are.
Pain. Okay. So Not something that I'd be concerned about intubation, but obviously concerned for a neurological injury. So if the therapist is able to maintain C-spine mobilization manually at this point, I would encourage them to maintain that throughout. And if we can get a C-spine collar in my bag and get that on them, I called it one.
Calling, you're waiting for them, so they're coming out. Okay.
Yeah.
So what other things are you going to do in the interim?
So I mean, at this point, we're concerned for a C-spine injury, making sure they're immobilized and we're staying there, monitoring vital signs. If we have a spine board, we'll leave them on to a spine board for transport once EMS gets there. It's not an essential thing at this point in time. Seeing if they're like if we're able to mobilize, if it's like an upper, if they're able to move their arms or legs spontaneously. So checking to see if there's any gross motor deficits at this point. Kind of moving on to a secondary.
Yeah,
survey.
keep reassessing.
Yeah.
Excellent. So I mean, these are things. I mean, obviously, you asked a great question. Are they supine versus essentially lying prone? If they're lying prone, that's essentially a consideration in terms of getting some help to do a log roll, so that you can essentially get them into a position to better manage airway breathing if necessary. But in a situation where you have an unconscious athlete, you just essentially continue managing and assessing to try and get as much information as possible for that transfer, and also to see whether when you're giving treatments, make sure that they're effective.
Right. I think it was one of the other cases we were talking about where if the patient's prone and they're actually conscious, but they have like neurological deficits, but they're speaking to you, that it's conceivable that it's okay to keep them in that prone position while stabilizing, like manually stabilizing the C-spine to minimize any sort of potential movement.
Yeah, it's an interesting scenario. I mean, if they were having, I would say if they're having neck pain, but no neurological deficits, and they're in some kind of weird, wacky, kind of awkward position, I think that's reasonable to maintain the C-spine immobilization. If they're in that same position and they're kind of tilted over and their neck is cranked, it's not unreasonable to try and consider bringing them back to essentially a neutral position in which you can essentially better manage your ABCs, and to see whether or not bringing them back into a more neutral position essentially relieve some of those neurological. It's kind of a rare situation. But there's also argument essentially with respect to that if they have those neurological deficits, maybe you shouldn't as little movement as possible. But the problem becomes, as we know, that if there was a significant essentially neurogenic shock, then you're talking about you're also going to have to manage your essentially heart rate and blood pressure. So it's an interesting thing, and I think although it's open for discussion, I think I don't think you would be wrong for essentially bringing them into essentially a position that allows you better management of the overall athlete. Okay, so the basics of C-spine immobilization is to mobilize as best as possible. That often involves essentially having contact points with both the head and the shoulders. And then from a clearance perspective, the bare minimum essentially is not having any neck pain, no midline tenderness, no neurological deficits, and able to tolerate a rotation comfortably for 45 degrees in each direction. Okay, that's what we just talked about there. In terms of C-spine collar application, I think the bottom message here is if you're not comfortable applying a C-spine collar, whether it's an Aspen collar or a Laerdal or a Miami J, you're probably best off just maintaining the C-spine immobilization until either a paramedic comes by or somebody who knows what they're doing. Because the last thing you want to do is essentially introduce further essentially unnecessary mobilization while trying to essentially force a piece of equipment you don't know how to use in. Okay. Finally, last piece is the heat-related illness, and here we're talking about both heat stroke, heat exhaustion. These are, once again, you have to keep in mind the environment. You have a higher index of suspicion for these, but these are once again that kind of confused, non-specific presentation of an athlete. So obviously you're looking at essentially the temperature out and the conditions and what the event is. So obviously an endurance event on a hot day, or certain endurance sports, so such as like field lacrosse, soccer, running, Ironmans, those kind of things, and looking for essentially a typical gait, and then obviously if somebody's collapsed, this is something that you want to consider along with the likes of like a hyponatremia picture. In terms of heat exhaustion, that's a lesser entity, but where essentially they may have profound headaches, profound fatigue, and obviously diminished performance. And there are ways of preventing this by essentially, from a medical officer's perspective, recognizing temperatures that are not safe for athletes to train or participate in. And that could be delaying the event or trying to have the event earlier in the day, depending on how much advance notice you have of it. So the use of a wet bulb temperature, if it's a moderately increased temperature, sometimes a lot of the sporting events, what we'll do is we'll increase the number of water breaks to allow athletes breaks to both get their heart rate down, but also get some fluids on board to bring that temperature down as well. And then finally, the other one, which trying to do more often, is essentially something called heat acclimatization. So especially for cold weather teams, to try and get to areas in advance to acclimatize to the warmer weather to reduce the risk of essentially heat-related injury. What I've done here is this is essentially from USA Soccer, and what they do is they also have a map associated with this. They identify different zones, and based on the zone, a certain range of temperature, different ranges of temperatures, which indicate essentially either not safe, safe with increased water breaks, and so on. So we have a fairly decent breakdown. You can see the category 1, 2, and 3, and that's based on essentially the different regions. Obviously green is safe to go, and those are the lower Fahrenheit temperatures there. In terms of the treatment for heat-related injuries, and specifically heat stroke, you want to activate that emergency action plan early. This is an emergency. Start cooling immediately, considering ice bath, ice to the axle and groins, removing any kind of dry clothing, getting wet clothing on, and getting some fans to cool off the hot air, checking the vitals, oxygen saturation, blood pressure, pulse, temperature, and as well as blood glucose, trying to get some fluids on board, and that's really what you want to do as you're waiting EMS to arrive. So I think that's enough for today. In terms of, in summary, I think once again we just, as Mark and Alex have demonstrated, the helpfulness of using an ABCD approach to any of these emergencies is very, very, very helpful. So taking a look at the airway, breathing, circulation, trying to get as much information as possible by checking those vitals, even if you don't have a blood pressure cuff, getting a pulse, checking cap refill. These are things that you can use. Immediately activating the emergency action plan upon identifying a situation that can be difficult to treat, or that somebody needs a hospital intervention, and doing what you can until that further help arrives. Thank you very much for those who persisted through the IT troubles, and for those who were present here in person. And we'll see you with the next Journal Club or lecture series.